Everyone, Dr. Hall here, and we're going to do our third lecture on the heart, lecture 26. So we've talked a lot about the anatomy of the heart, the path of blood flow through the heart, the conduction system that helps orchestrate the whole cardiac cycle, and the importance of timing. We've also looked at some EKGs where we can see the electrical tracings of those signals. So what we're going to talk about today is how we measure cardiac function and then how that is regulated. So the basic measure of cardiac function is how much blood is being circulated through the body in a given period of time. So we have this phrase cardiac output. And so the cardiac output is the volume of blood that's circulated through the body in 1 minute. So how do we calculate that? Well, so the cardiac output is going to be equal to how much blood is pumped out with each heartbeat, which we call the stroke volume, times how many times does it beat in a minute, the heart rate, right? So it's like, okay, if I pump out 60 cc's of blood with every heartbeat, if 60 is my stroke volume, 60 cc's or 60 mLs, and let's say my heart rate is 100, just to make the math easy. So 60 times 100 would be 6,000 or 6 liters of blood moved through the heart in a minute. Now, normal body blood volume, if I were just to kind of open up my blood vessels and drain all my blood out into a bucket, I would fill probably about 5 liters. So you basically circulate your entire blood volume through your body about every minute, which is kind of interesting to think about. So we have this neat formula that cardiac output equals stroke volume times heart rate. So what are the things, however, that influence stroke volume and heart rate? So stroke volume, as we talked about, is how much blood your heart pumps out per beat. So what we're going to do now is you are going to estimate what your own personal stroke volume is. So the first thing I want you to do is to measure your pulse so that you can find your heart rate. So you can feel it in your wrist, you could feel it in your neck at your common carotid artery, or if it's hard for you to find your pulse, you can lay down on a mattress with your ear on the mattress and sometimes you can hear your heartbeat. So go ahead and pause the lecture, pause the recording, and count your pulse, right? So either count it for a full minute, and that will tell you how many beats per minute, count for 30 seconds and multiply times 2, or count for 15 seconds and multiply times 4. So go ahead and take a moment and figure out your heart rate. So now, in order to figure out your stroke volume, we also have to know your cardiac output. Now, short of, putting some really invasive catheters in your body and hooking you up to some pretty expensive equipment that's really invasive, I can't actually measure this. So we're going to have to use some general reference ranges. So female-bodied people usually average around 5 liters. Male-bodied people, usually their cardiac output is 6 liters per minute. I apologize, I don't have the appropriate units there. It should be 5 liters per minute or 6 liters per minute. And just remember that 5 liters is 5,000 milliliters, 6 liters is 6,000 milliliters. So now how are we going to calculate our stroke volume? Well, so some simple algebra, right? So if cardiac output equals stroke volume times heart rate, we're going to solve for stroke volume. So you're going to take that cardiac output of either 5,000 or 6,000 and divide by your heart rate. And that should give you an answer, which would be in milliliters per minute. I'm sorry, just milliliters. Ugh. I have to cross that out, just be milliliters. Okay, so what you're going to do is then enter your result in the discussion board that I've posted for your in-class activity for today, and you will get credit for that. So don't forget to do it, okay? All right. So cardiac output is stroke volume times heart rate. So heart rate, we've talked about before, that's going to be determined by the SA node if everything is working correctly. That's the pacemaker of the heart, located high up in the right atrium, sends that initial signal, which perpetuates through the cardiac myocytes of the atria in a wave-like fashion, ultimately is going to reach the AV node, which will pause it for a moment, then lightning fast will send the signal down through the AV bundle, right and left bundle, and the Purkinje fibers, so we get a big concentrated ventricular contraction. We know that the SA node receives innervation from the autonomic nervous system, and we'll talk about that a little bit later. So that's what's going to determine your heart rate. Your stroke volume, right, so how much blood your heart pumps out with each beat is going to depend on a variety of factors. One of them is, well, how much blood is in the ventricles that can be pumped out, right? So you can't pump out more than is in there. So that's going to be a major factor. And so that's determined by how much blood is coming into the heart. And of course, blood coming into the heart is coming in through veins. So we call that venous return. Now, if you happen to have some blood loss because you had a major accident and you're bleeding, or you're in surgery and you're losing blood, or if you're really dehydrated, which can decrease the amount of plasma you have in your blood, so your total blood volume is low, those things can decrease your venous return, right? There's just less blood coming in because there's less blood volume overall. The other thing that's going to determine how much blood is in the ventricles is how much time you have to fill them. So remember, ventricular filling happens during phases 3 and 1 of the cardiac cycle. So when the atria and the ventricles are in diastole and when the atria contract. So how much time do we have for that blood that's coming toward the heart to actually move into the ventricles, and how good are the atria at pushing it in? The other thing, so not only how much blood is in the ventricles, but then how forcefully are the ventricles pushing it out, right? So we call that contractility. That's a function of the cardiac myocytes themselves, and it's going to be due to whether or not they are getting sympathetic nervous system stimulation, as well as how fully the ventricle was filled. Because if it fills nice and fully, you get a good little bit of stretch on those ventricular walls, that allows you to get an even better contraction out of it. That's called Starling's law, and the best way I can describe it, and I wish we could be in person because usually now I squirt water all at you, is if you're in a water fight with somebody and all you have are these squeezy bottles, right? You are going to get a lot more force if you fill the bottle up all the way. If the bottle is only partly filled, you can still squeeze some water out, especially if you hold it upside down, but it's going to be much less effective at ejecting water out of that chamber. So having it nice and full can really increase your ability to then push the blood out. That's called Starling's law. It's not in your textbook, but it should be. Okay. So now we know the factors that are involved in determining cardiac output, stroke volume, and heart rate. How do we actually regulate the heart, and how do we actually regulate cardiac output? So first of all, we just have to remind ourselves, if we're talking about organs, inner organs, and sending efferent signals in terms of how they're supposed to contract, then we are talking about the visceral efferent nervous system, otherwise known as the autonomic nervous system, which has its two branches, sympathetic and parasympathetic. Hooray! You might remember this diagram from before. So you can see that over here on the left, right, is the sympathetic division. You might remember that it sends signals down to ganglia located in the sympathetic chain here, and then they're going to come out to the different organs. So one of the things the sympathetic nervous system does is constricts blood vessels, which helps increase blood pressure to help increase delivery of blood to the tissues. But it also is going to accelerate the heartbeat by stimulating the SA node, and it's also going to increase contractility in the ventricles, right, by making those cardiac myocytes pump harder. On the other side, we have the parasympathetic division, which you'll remember sends nerve fibers via the vagus nerve over here, V for Vegas, And the only major contribution of the parasympathetic nervous system to the heart is that it will tell the SA node to slow down. Okay, so without the sympathetic nervous system, then your contractility goes back to normal. So what are the things about the heart? This is review that we can regulate, right? So heart rate or pulse from the SA node, sympathetic nervous system will increase it, parasympathetic nervous system will decrease it. We can also change the contractility, which is a function of the cardiac muscle. Sympathetic nervous system will increase contractility and parasympathetic nervous system won't purposefully decrease it. It's just absence of the sympathetic. So how does the body know to activate one or the other branches of the autonomic nervous system? How does that actually get involved? Well, you have to have informants. You have to get information about what's going on out there on the ground. So we have some informants that are going to send signals to the medulla oblongata about what is going on out there. First are the baroreceptors. We've talked about these earlier when we talked about blood vessels and regulation of blood pressure. So these are pressure sensors located in both the aorta and the carotid arteries, and they're going to send signals to the medulla oblongata as to whether our blood pressure is just right, too high, or too low. We also, and this is new, you haven't learned this yet, we also have chemoreceptors. So chemo just means chemical. And so what they're actually sensing is pH, which you'll remember is a measure of how acidic or basic something is. They are also located in the aorta and the carotid arteries. So if you're really active, right, and you need lots of ATP, you're doing lots of aerobic cellular respiration, which you might remember not only requires oxygen, glucose, and mitochondria to do the work, but also generates carbon dioxide as a waste product. Carbon dioxide is acidic. When you dissolve it in a fluid like plasma, it becomes acidic, and so the pH falls, it gets lower. The blood gets more acidic when you are more metabolically active, such as during exercise, when you're using up more, you're producing more ATP. So what happens then is those chemoreceptors tell the medulla oblongata, hey, we need to rev up the cardiac output because we're generating more carbon dioxide, so we need to move the blood through the system more quickly so we can get rid of this carbon dioxide as quickly as we're producing it. So the medulla oblongata is going to activate the sympathetic nervous system, heart rate and contractility will increase, therefore cardiac output increases, therefore you can get rid of that extra carbon dioxide. And I should have animated this before. This is just that reminder that aerobic cellular respiration requires oxygen and glucose, and then it's going to produce 36 ATP, but waste product here of CO2, carbon dioxide, which is acidic. So this is just a table to kind of summarize how these different factors are influenced by the autonomic nervous system. So if you want to increase vasoconstriction, we're going to turn on signals from the sympathetic nervous system. To decrease or to allow for vasodilation, you're just going to turn off the sympathetic nervous system. For heart rate, this is the one that's different. So this one kind of makes more sense. So the sympathetic nervous system will increase heart rate, and the parasympathetic nervous system will actively decrease heart rate. And for contractility, it's more like vasoconstriction. The sympathetic nervous system will increase contractility, and the parasympathetic nervous system doesn't really do anything. So if you want to decrease contractility, you just turn off the sympathetic nervous system. So now we're going to go through a few case studies so you can see these things kind of in action in some real life scenarios. First of all, we're going to talk about normal physiologic response to changes in the body's needs. So here's Rita. She should be farther away from her friend, right? She should be 6 feet away. I'm not sure if she's quite 6 feet away in this image, but she goes out for a run with her friend. So her muscles are demanding more oxygen and glucose, and they also need wastes and carbon dioxide to be taken away and disposed of more quickly. So take a moment to think about what needs to happen in this situation. So she needs to increase her cardiac output, right, in order to increase delivery of oxygen and glucose, as well as to increase the rate at which she removes carbon dioxide. So that means that she wants to increase her heart rate and her contractility, because increasing contractility will increase your stroke volume, thereby increasing cardiac output. She also wants to increase her blood pressure. So normal response to exercise is to increase blood pressure so that you can more quickly deliver blood to the tissues that need it, right? So that example of using a garden hose, if you have it on low, you can't quite get as much water as quickly and you can't get it as far. So we want to make sure we have really good blood pressure to make sure we're getting blood to all the areas that need it. So let's think about, how do we make this happen, right? So what system are we going to activate in order to cause these effects? So her chemoreceptors are going to sense increased carbon dioxide because of the increased generation of CO2 due to aerobic cellular respiration. The chemoreceptors are going to send a signal to the medulla. The medulla oblongata is therefore going to activate the sympathetic nervous system. Those sympathetic nervous system neurons that send down to the ganglia in the sympathetic chain are then going to signal the SA node to increase the heart rate, signal the cardiac myocytes in the ventricles to increase their contractility, and signal the arteries to vasoconstrict, thereby increasing blood pressure. So after her run, she decides to sit back and relax with a good book. So her body needs now are going to be quite different. Now in the first 10 minutes or so after exercise, you have an oxygen debt, and so things are a little weird in the immediate recovery period. But after she recovers from her exercise and wants to just relax, she needs decreased heart rate, decreased contractility, and decreased blood pressure back to normal. So how do we do that? The medulla again is going to activate, this time, the parasympathetic nervous system, and that's going to slow down the SA node and slow down her heart rate. It's also going to turn off the sympathetic nervous system. Therefore, the vasoconstriction reverses. We go to vasodilation. Things just open up, so blood pressure falls, and the myocytes will decrease back to normal contractility, and so we'll get back to a normal cardiac output. So let's talk about what happens with illness or injury, right? So how do we compensate for when something in the system has gone wrong, okay? So let's talk about Belinda. She's in a car accident and had extensive wounds to her legs that bled a lot. So when the paramedics arrived on the scene, her heart rate was elevated at 140 beats per minute. So now let's take a moment and think about why her heart rate would be so high. Now you might say, well, because she's in pain or she's really stressed out, which is probably true. But let's talk about kind of the other factors that could be causing this as well. So if you're bleeding a lot, your total blood volume will decrease, right? So your venous return decreases. Therefore, your stroke volume decreases. Therefore, your cardiac output decreases. And if you don't have enough cardiac output, then your blood pressure is going to drop. So the baroreceptors then are going to signal the medulla oblongata, say we have a problem here, blood pressure is too low. Medulla is going to activate the sympathetic nervous system, which is going to cause the SA node to fire more rapidly to increase the heart rate. It's going to tell the myocytes to contract more forcefully to increase contractility. So those two things together will increase cardiac output. And then it's going to also signal the arteries to constrict so that we can maintain sufficient pressure in the system to deliver blood to all the essential organs. So that is why her heart rate is 140. So what would it mean in this situation if her blood pressure was very low? Let's say Belinda's normal blood pressure is 110/70. Let's say that when the EMTs measure it in the field, not only is her heart rate 140, but what if her blood pressure is now 90/50, right? What if it's 80/50? What if it's very low? What does that tell us? Well, first of all, her sympathetic nervous system is activated. So the whole point is to maintain sufficient cardiac output to maintain sufficient blood pressure to get blood to all the tissues where you need it. So if her blood pressure is low, this is an ominous sign, right? This tells us that her body, despite pulling out all the stops, is unable to maintain sufficient cardiac output and sufficient blood pressure to perfuse her tissues, to deliver blood to all of her tissues. So if that happens, this is a life-threatening emergency. This is someone who absolutely needs IV fluids right away and might even end up needing a blood transfusion. Right? So what IV fluids are going to do is they're going to increase the amount of plasma that you have in blood and increase the blood volume, which will help increase the blood pressure. Right? It certainly in the short term isn't going to increase your erythrocytes, right? It takes a while to make those. We can't make those really quickly. So she might need a blood transfusion also. But sometimes even just with IV fluids, you can tank people up enough to maintain their blood pressure sufficiently that even though they're relatively anemic, you're still at least getting oxygen and glucose delivery to the tissues. Maybe a little less than normal, but you're still getting it. Let's talk about Randy. So Randy develops a heart block where the AV node can't get signals from the SA node, right? So we talked about that before. And remember how the AV node will generate signals of its own, but at a much lower heart rate, so about 40 beats per minute. So if this is a normal EKG here with a normal heart rate, this is a much slower heart rate down here. And we can see they've labeled the P waves, and you can see that the P waves have no relationship to the actual ventricular contractions at all. So the ability of the signal from the SA node to actually be received by the AV node is not working. So we have an AV nodal rhythm or maybe even a ventricular rhythm in this person. So it's much slower. So with a heart rate that's really low, right, his cardiac output is going to go down because his heart rate went down. So his body is going to try to compensate. So we're going to activate, right? So blood pressure is going to go down because cardiac output went down. Baroreceptors in the aorta and the carotids are going to signal the medulla oblongata, which is going to signal the sympathetic nervous system to tell the ventricles to pump harder, right? To increase stroke volume to try to get that cardiac output back up. Now the sympathetic nervous system will also be signaling the SA node, and so the SA node may fire more rapidly, but that's not translating into actual heartbeats for us in this situation. So we're also going to try to increase blood pressure to increase delivery to tissues, and so we're going to vasoconstrict as well, especially in non-critical body areas. So a lot of times if people have decreased cardiac output, their body is trying to conserve blood pressure and blood flow specifically to the areas of the body that are keeping them alive. So to the heart, to the brain, to some of the major muscles. And so what you'll see oftentimes when people aren't doing well from a cardiac standpoint for one reason or another is that they'll look kind of pale and have kind of a grayish color to them. And that's because they're really vasoconstricting in the skin. Right? Skin is kind of a luxury item at this point. Just, leave it be. We'll get back to it later. Also the extremities, so their fingers and their toes may get kind of cold or pale. You'll be sending less blood farther out into the body. Kind of very similar to what we do for cold, but a little bit different. The other thing that you'll see is because the sympathetic nervous system is activated, they'll also tend to get a bit sweaty. Right? So if you've ever heard of descriptions of people having a heart attack and how they often look kind of gray or pale and sweaty, right? That's because of the activation of the sympathetic nervous system as their body is trying to compensate for the fact that their heart isn't functioning well in that moment. So let's say that Randy's heart then goes into another abnormal rhythm due to a problem with his conduction system. This is an example of what we call a reentry tachycardia. So now his heart rate is 175 beats per minute. That's really fast, right? That's fine when you're exercising. That's appropriate when you're exercising. But if you're just at rest, that feels pretty lousy. And one of the reasons that that feels lousy is because your filling time now is really, really short. So the ventricle just doesn't really have an opportunity to fill sufficiently before it has to beat again, right? It's like you're trying to fill up your water bottle at the faucet, but somebody keeps pulling it away and making you squeeze it before it's full, right? So your cardiac output in this situation, when the heart is abnormally going really fast, your cardiac output is going to fall. So you might be like, well, Dr. Hall, what's the difference when you exercise and your heart rate goes up to 175? Well, when you exercise and your heart rate goes up to 175, it's because your sympathetic nervous system is activated. So it's also increasing contractility, it's also increasing blood pressure, so you get faster venous return, right? So you're compensating really well for that. But this is also why, when people talk about maximal heart rates during exercise, you don't want to go too high, right? And so a lot of trainers will make sure you don't exercise to a point where your heart rate goes beyond a certain level. Because when your heart rate gets super high, you really get no increase in cardiac output because filling time is then so short. All right. So we've talked a lot about the heart this week. So we talked about the anatomy of the heart, how it's a double pump. The right side receives deoxygenated blood via veins from the body and the heart muscle through the coronary sinus. And then it goes right atrium, right ventricle out through the pulmonary trunk, pulmonary arteries into the lungs, comes back through the pulmonary veins into the left atrium, then into the left ventricle, gets pumped out through the aorta to the body. We talked about how the heart valves are specialized for their functions. The AV valves have those really cool accessories of papillary muscles and chordae tendineae. And the semilunar valves are a little bit more delicate. They're still pretty robust, but they don't have to be as strong as the AV valves. Our heartbeat is due to the closing of the valves, right? So first the closing of the AV valve slamming shut when the ventricles contract, and then the semilunar valve slamming shut when the ventricles relax. We have that cardiac cycle where both chambers, or all four chambers, are in diastole. Then the atria contract, we call that systole, and then the ventricles contract. We have a conduction system to make sure that everything is coordinated with the SA node, then the AV node, AV bundle, right and left bundle branches, and Purkinje fibers. We can use EKGs to learn a lot about what's happening with somebody's heart and their conduction system specifically. So the P wave is that action potential traveling through, or depolarization is the other word that's used, traveling through the atria is kind of a slow wave. Then we have that QRS complex, which is that big, spiky, narrow part of the EKG, and that's the ventricular contraction as that signal zips through the AV bundle, right and left bundles, and Purkinje fibers. And then the T wave, which is ventricular repolarization, resetting for the next beat. We talked about pacemakers that can be used for people whose SA node or AV nodes aren't working properly. And then we talked about the coronary circulation, so the fact that the heart muscle itself has its own set of arteries and veins, and that coronary artery disease and the blockages that can occur due to atherosclerotic plaque can then decrease blood flow to areas of the heart muscle, and if those areas of heart muscle die due to decreased blood flow, that is what causes a heart attack. We talked a little bit more about atherosclerosis and the risk factors such as high blood pressure, high cholesterol, diabetes, and tobacco. And then we talked about how we measure cardiac function today. So cardiac output, which is equal to the stroke volume times the heart rate, and that is the total volume of blood that is circulated through the heart in 1 minute. Then we talked about how we regulate the cardiovascular system using the autonomic nervous system. So our sensors are the baroreceptors for pressure and chemoreceptors for pH that are located in the aorta and the carotid arteries, and they're going to signal the medulla oblongata, which will then activate one or the other branches of the autonomic nervous system depending on what you need to see happen. So I hope that made sense, and the quiz will be posted. Take your time, ask me questions, post them to the discussion board, and I hope you're all doing well.